presentations, but we'll get started. My name is Michael Stevens. I'm a pediatric gastroenterologist at the Mayo Clinic. I'm excited that we have our other speakers that are coming after me because I'd like to make this as participatory as possible. Let's see if I can advance the slides here. Maybe. There we go. So I do get research grants from 2 pharmaceutical companies. We're a part of multiple clinical trials that have to do with newer medications getting approved for pediatrics. That does not actually support my salary. That just supports the research that we're doing with that. But I would want to be transparent about that. I think this is on every program that we have. So like I said, I would like this to be as interactive as possible. So I'm going to talk about several kind of recent advances that were driven from the pediatric side of things, but I'd sort of like to use that as a way to just start a conversation. And so if you have any questions, just interrupt me, please. And so again, I'd like this to be more of a forum where we're interacting with each other and I answer your questions. If this goes in a totally different direction from my slides, I think that's fantastic. Okay, so let me start a little bit by just talking about what causes inflammatory bowel disease. Usually when I'm speaking at conferences like this, I meet parents and patients who have very sophisticated understanding of this, and other people are very new at this. So we don't entirely understand what causes inflammatory bowel disease. And it really, a number of things have to come together in, I'm not sure I'd say the right way, the wrong way for an individual to get this. So genetics plays a role, but it's not like the genetics you learn about in high school biology. They're not recessive or dominant genes. There are actually almost 200 genes, a little over 200 genes that are connected to inflammatory bowel disease. So the way that I think about this, I'm going to close the door while I'm talking, is the genetic hand that you're dealt. Hi, come on in. Good to see you. So the genetic hand that you're dealt has an impact on your risk of developing this disease, but there are other factors that are involved. And the amount that we know in each of these spheres is different in size as far as our knowledge base. So I think we know a lot about the genetics. That's like a defined thing to study, right? I mean, there's a lot. There's like 2 billion letters, but that's it. So it's easy to kind of get to the bottom of that. Other factors that are involved include your microbiome. So we coexist with a whole population of organisms. And our understanding of that fraction has changed. I used to say, if you throw me in a blender and you make a slurry of cells, only about 30% of those cells will be me. The most recent one I heard is maybe closer to 50-50. But we have this complex relationship with all of these organisms that colonize us. A big player in that relationship is our immune system. I wonder how I did that. Our gut is this huge immune interface with all of those organisms that are living there, but then everything else that we put in there, all of the food that we eat, all of the stuff that comes out of a smokestack in an electrical plant in Idaho that we end up swallowing. So all of those things, this kind of went into its advertise mode. Basically, that is a very complex interaction that's happening. And when somebody develops Crohn's disease or ulcerative colitis, that interface becomes dysfunctional. And that's how you end up with the chronic damage. So when somebody's diagnosed with Crohn's disease and they have a colonoscopy and we see these ulcers, that's that dysfunctional relationship, is the consequence of that. So the way that one way that I conceptualize this is every patient I see probably has a unique version of this disease. that's determined by their genetics, their microbiome, environmental factors, a whole host of things. And I think that gives us, as physicians, it's a big challenge, because there's not a one-size-fits-all approach. I can't look at that individual's numbers and send the medical student to the library and there's a single answer that for how we treat that or what's going to be best for that person. A lot of the research and the advances that are happening right now are really geared at trying to figure out how to break people into maybe smaller subgroups of disease where we can make more intelligent decisions at the beginning. So, right now we try to divide, we have for almost 100 years divided this into Crohn's disease and ulcerative colitis, with maybe a group in the middle where we're not totally sure, where we say indeterminate colitis. But really, even within those big groups, we're beginning to understand there are specific subgroups. And some of the research that we've had recently has told us some of our new treatments work great for some of those people, but not for everybody. And so I think a lot of us are trying to find, how do we figure out which group that individual is when the diagnosis is made so that we can make a better decision. There are some other big steps that have to happen after that, because as we're getting to a point where we may be able to predict how an individual will respond, we don't always have a solution if they're necessarily somebody who's going to be more difficult to treat. I'm going to come back to develop, and I think you may have, I don't know if you talked about this. This is about safety, but since I started talking about stratifying patients, let's talk about what we called the risk study, which was kind of a big step forward in pediatric research, because I think it created a collaborative network that really started to answer some of these questions. And like Dr. Steiner was a part of this group as well. I think this was before we started this before your time. So this was a study where we looked at children when they were diagnosed with Crohn's disease and followed them. And we collected all kinds of specimens to try to profile them. So we collected DNA, we collected blood to look at what their immune system was sensitized to look at like antibodies. We collected stool to look at their microbiome. We collected tissue samples during their colonoscopy to look at factors in the tissue. Mostly what we looked at was in the tissue what was switched on and off in that individual's immune system. And the way that we measure that is by measuring little fragments of RNA. So if something is switched on in a cell and that gene is activated, it's making many copies of RNA to make that product. And we anticipated that a certain number of patients were going to have complications based on historical experience. There's a certain percentage of children that are going to need to have surgery, for example, within 5 years of being diagnosed. And we use that to what we call power the study. So to decide how many patients do we need to follow in order to be able to measure these differences. And this we actually did. We did find things, and this was the original publication or the primary publication of that. What we found, and this is kind of very scientific, but what we found is differences in behavior could be predicted by what was switched on and off in that individual's immune system in their tissue. So there are some patients whose Crohn's disease causes what we call just inflammatory behavior. It causes inflammation, but it doesn't cause a lot of other complications. There are some patients who develop what we call penetrating disease, where that inflammation actually creates a hole in the wall of the bowel inside the abdominal cavity. So you can get a fistula or a connection between two loops of bowel or the bowel and another organ. And then there's a group of kids that get scarring. So they get inflammation, the tissue gets swollen, and eventually they start laying down scar tissue. And we saw a difference between kids who had stricturing behavior, that behavior, versus other types. And this looks at, this is expression of all kinds of different cellular functions in their tissue from their colonoscopy. And so the kids that were more likely to get a stricture had abundant revving up of kind of remodeling things that put down collagen, scarring behavior, the things that regulate that. And the kids that didn't get strictures had a very different profile that was more kind of, we called it cytokine storm. Cytokines are some of the messengers that turn on our immune system. And so they had a very different profile. So there's a potential that we could look at that when somebody's diagnosed and stratify that. Now we need to kind of validate that and get that into a test that you can order as a clinical thing, as opposed to a really finicky research test. And then then there's more steps beyond that, because if we can identify who those kids are that are likely to get a stricture, we still have to find a treatment. But I think that can help us design better clinical trials in the future, where maybe people are enrolling in a drug that's designed specifically for that type of profile, and we're only enrolling patients who have that profile. So that was pretty exciting. The other thing that came out of that was interesting was when we looked at outcomes, we saw that the treatment that we started with had an impact. And in this specifically, we looked at anti-TNF treatment. Medicines like Remicade or Humira would be the things that you might be most familiar with. And so when we looked at, this is sort of like everybody, the whole cohort starts here. And if we look at patients who have basically who either have stricturing behavior or inflammatory behavior, stricturing, inflammatory, or internal penetrating behavior. This is what happens is that they start at 100%, but as they get surgery, that percentage of people that, it's basically who doesn't have surgery. And so the people that had stricturing behavior were much more likely to have surgery. And then if we compared people with stricturing behavior versus inflammatory or penetrating behavior, and we stratified by whether they were treated with anti-TNF medicines, the people that got early anti-TNF medicines had much less surgery, except for people with stricturing behavior. So the two blue lines are early or no early TNF, and that ends up in the same place. So this is one situation where we identified a factor or a subgroup of people that were going to do better with the treatment. It actually was a little bit of a surprise, because in the end, because of this effect, there were fewer kids that had surgery than we predicted when we designed the study. So the results of that really were we found some signatures that can help us stratify patients and try to predict how they're going to respond to some of the treatments that we commonly use, and also find people that maybe aren't likely to respond to what we might typically use. Now we have to figure out what to do with that. I'm going to jump around. So that led to another similar approach with that group of people looking at ulcerative colitis. And again, kind of a similar approach. What was a little different is in the risk study, the first one that I showed you, there was no prescribed algorithm about how we treated patients. Everybody followed their own proclivities of what medicines they chose as far as the treating physicians. And that's why we were allowed to compare different treatments. in this study, everybody followed the same algorithm as far as treatment choices. It was really complicated. I'm not going to show that diagram. But people followed the same approach. And again, we collected samples just like we did in risk, looking for things that can help us stratify how disease behaves. And this was a smaller group of kids. It was about 400. But the idea was, can we predict which kids, when they're diagnosed with ulcerative colitis, are likely to respond to a medicine called mesalamine? So that's how the standardized treatment approach are going to be a year later in remission on that medication. And I think most of us, if the three of us think about our collective experience, is there are some kids that do great with that, but not as many as we would like. And so it would be nice if we could figure out who they are and not delay moving on to something that's more likely to be effective. And so they did find a number of things. Let's see if I can get this to work. This actually provided some information for us that was much more practical. So instead of measuring RNA in biopsies, they actually found some things that information that we run across in the clinical care of patients. So if patients, based on their symptoms, when you go to the doctor, we always ask you, how often do you poop? You know, we have this whole scoring system. In UC, it's called PUCI, which I think is kind of funny that it sounds like that. I know the person that developed that. Anyways, so if no matter how sick you are when you start out, if you're doing really well at 4 weeks, that was very predictive that you were going to be able to succeed, so to speak, at treating that disease with mesalamine, even in patients that were sick enough to end up in the hospital. So I think there was a perception in the medical community that if a child at diagnosis is so sick that they have to be in the hospital, maybe we're not likely to get this medication to work in controlling their disease. We sort of think of that as it has this reputation as a milder medication, right? So medicines like Remicade, they go systemic. They have a systemic impact on how your immune system works. Mesalamine is an anti-inflammatory medicine. Its mechanism of action is kind of like aspirin. And it's an oral medicine, and it's more like lotion for your colon. It coats the mucosa and has anti-inflammatory properties. So we were able to kind of have something that anybody can start to use in the office as far as predicting whether somebody's going to respond. So the flip side of this is patient comes back for follow-up in 4 weeks and they're not doing well, even though they might be on mesalamine and they may be on steroids on top of that. It's probably time to start planning on your next step. And that, I think, is very useful as opposed to like 3 months of up and down on steroids until you say, okay, I guess this isn't going to work. The other thing that we saw sort of on the other side of that is some things that you might find when you're making the diagnosis. So kids that had very low vitamin D levels, and then something that we can look at with our pathologists in the biopsies of the rectum, where we count a specific type of white cell. If they had those patterns, they were more likely to either need what we call escalation, so changing to something like Remicade. I'm hoping you're going to ask questions, because when I'm talking about medicines like this, many people are familiar with them, but not everybody. So again, interrupt me. So we found a number of things that seem to predict people that were going to be more difficult to control. So putting those together, that can be very helpful. I think I'm going to go backwards. Yes. So let me go back to a couple of other things. One thing that I often feel like I hear myself saying when I'm having conversations with families about starting a new treatment or what treatment to use is that I feel like we're often making decisions knowing we have less information than we would like to have to make that decision. And I think that's very much the case when it comes to drugs and pediatric patients. It's more than half of the drugs prescribed by pediatric providers are not FDA approved for pediatric patients. And so it kind of starts out with this approach of, okay, if an adult's this big and my patient is this big, you know, I guess that's the dose we'll start with. Although most of the, like I was saying, we're a part of clinical trials in pediatrics for drugs, and most of what they're focused on is trying to identify what the appropriate dose is for children. We've already sort of established that it works for, you know, that it's effective for at least a subgroup of people. It's really about how do we use it correctly in kids. So when Remicade, infliximab is the generic name of that, was first approved at the turn of the century. So in 2000, there were 0 drugs approved for Crohn's disease. So that was considered what's called an orphan drug. And so at the FDA, they had a different pathway for approval, which actually fast-tracked it. But a part of that is if you go on that fast track, the FDA mandates things like very granular post-marketing surveillance. So the develop registry was mandated, and almost every academic pediatric center in North America was a part of this. And this again, didn't just look at Remicade, this looked at all of the kids that we were taking care of were enrolled in this, and it's a safety registry. So the goal is we get a large number of patients, 4,000 Crohn's patients, 2,000 colitis patients. That's pretty unheard of in a pediatric study to have numbers like that. But the whole point of this is to look at safety. Now, in this case, the primary comparison is people getting Remicade versus not, because this is part of the approval for that. So they did follow almost 6,000 patients. And again, the things that we were looking for, the primary thing was malignancy and other kind of pre-malignant conditions. There's a problem called HLH, which is sort of a pre-malignant condition of blood cells. But these are super rare events, but not good events. They're very high risk for the patient. So they compared patients that were on Remicade. They broke this down by, since we've got people on lots of medicines, this was broken down by into a large number of subgroups. And I'm sorry for the chart, which may be confusing, but basically in each group, based on their therapy, if the whole box and whisker plot is above the line, that represents a departure in the risk in a bad way compared to a big database that is used to sort of say, okay, what is in the general population, what is your risk of this cancer? So there's a huge NIH-funded thing for that, for not just these kinds of problems. So when we looked at this is kind of the main conclusion of this is if you took Remicade, here's 2 Remicade groups, either with a medicine that we used to combine with it, this didn't get above there. If you took any medication that's a biologic, Remicade or Humira, with what we call thiopurines, that is a little bit higher. And then if we just compare thiopurines versus not thiopurines, we see increased risk. So that really kind of changed our behavior as physicians when this came out. So we didn't understand this until, well, it was like 2017 that came out. We weren't sure. So Remicade has a black box warning about these types of complications. Now thiopurines, which are like 6-mercaptopurine, azathioprine, have that black box warning. And I think what most experts would say, this is probably an effect of the thiopurine as opposed to the anti-TNF medicine. So we've transitioned. When I finished my training, it was routine for us to combine those medications because you would get a number of benefits. You'd get extra therapeutic oomph, and it would also protect the patient from developing antibodies to Remicade, which can be a reason why it stops working. I think most of us now don't do that. We might consider that in somebody who's developed antibodies to Remicade and they're going to go on a different anti-TNF like Humira. We've also focused more on finding alternative medicines to do that. So methotrexate is another medicine that has been shown to help prevent antibodies. Hasn't really been shown to give us any extra therapeutic oomph in GI diseases. It does in rheumatologic diseases. But, so this is a problem. We actually answered a question in kids, something that we've been like wringing our hands about for more than a decade. And now we understand a lot more about the safety. Questions? Yeah. Correct. Yeah, I mean, it's, so there's a couple things that have an impact on your risk of getting that. Taking an immune modulator, or whether it's methotrexate or a thiopurine, protects from that a little bit. And also maintaining reasonable levels. So if your level goes to 0 and then you get it back up, you're at a higher risk of developing antibodies. So 20 years ago, when Remicade came out, some people used it like steroids. Like you'd get somebody in remission and then try to go back to mesalamine or something else. And so that's why typically if we think somebody needs Remicade, we're sort of committing, okay, we're going to do that unless there's a reason to stop, like you get antibodies and it stops working, or it doesn't work, because unfortunately it doesn't work for everybody. Yeah. You can yes, you basically have to request it specifically, but it's a blood test that we send. Yeah, yeah. At the physician meeting this morning, there was a whole discussion about that, because we can measure drug levels, we can measure antibody levels, and there's a big debate in the medical community because we have conflicting data about whether we should proactively do that or reactively do that. I think everybody agrees that reactively doing that makes sense. You know, if you come in and say, last 2 infusions, I could tell it wore off the week before, then that probably makes sense. We don't know if, like, should you just check it once a year? Mixed information about the utility of that. Which leads into the last thing I was going to talk about, concept. Sorry, I'm skipping around, but so medicines like Remicade are typically dosed based on weight. And that's something that as pediatric providers we're pretty comfortable doing. That was sort of a new concept for our adult colleagues when these medicines came out. But what we've learned is that it's not a linear relationship between weight and how rapidly people clear the medication. In fact, younger kids clear these medications faster. I think another part of that is younger kids have a different body composition than somebody who's old and rickety like me. And so if we compared, there's some studies that looked at younger kids, and this was the situation, in this study, everybody had drug monitoring. So they checked levels in everybody. It wasn't on demand or reactive. And the younger the child, the more likely they had to make a change upward in the dose compared to kids that are maybe closer to an adult situation. And this came out of the, so when as a result of the pediatric clinical trials that led to Humira, one of the, that's what adalimumab is, which is another anti-TNF. The doses that we give to our younger patients are actually different than adults. So if I have ulcerative colitis versus my 16-year-old patient, my 16-year-old patient would get a higher dose than me, would get an extra dose in the induction series. So there's this cliche in pediatrics that kids are not little adults, and this is an example of that. Yeah. Well, they get a different dose too. So an adult would get 160 milligrams on day 1, 80 milligrams in 2 weeks, and then 40 milligrams every 2 weeks. In a larger kid, they get 160 milligrams. Then they get a week later an extra dose. So they get an extra induction dose. Week later and 2 weeks later, and then maintenance. Yeah. Probably because that may have happened before this information came out. This is relatively recent. Okay. It also depends on now I'm getting confused here. Yeah. Yeah. I'm not sure I can explain all of that. Yeah. Yeah.
I will tell you, in practice, sometimes insurance companies come up. They're not
Correct.
following the FDA guidance 100%. It hasn't fitted in the formulary yet. So despite our appeals and our struggles and our phone calls to try and get the right medicine approved and covered, sometimes you are stuck at the mercy of what the insurance will pay for. These are pretty expensive drugs. So I would rather get my patients started on the drug sooner than continuing to battle for weeks.
Right.
That quote-unquote right dose. I think it's, as Mike talked about, checking these drug levels can be really important. So doing a drug level and taking that level back to the insurance company, whether it's a month later, 2 months later, can give us maybe some more objective data that, hey, this is nothing we need to adjust.
We're actually, I think I'm a little bit over time. I think I'm supposed to be 20 minutes, and we're a little bit longer, but I'm happy to answer more questions.